I'm Asheesh Bedi. I'm one of the orthopedic surgeons here at the University of Michigan in Ann Arbor. I'll give you a little bit of background on myself. I want to keep this fairly informal. I think that's sometimes the most helpful or beneficial. We have another Dr. O in the back is kind of, you know, I'm a sports surgeon or shoulder surgeon in the division of sports and shoulder surgery. So my area of interest has been, frankly, in that area, and it's mainly joint preservation surgery. So what do I mean by that? You know, I have lots of good colleagues in my division that do surgery kind of for arthritic or worn joints where knees or hips or shoulders have gotten to a point where they need to be replaced. I do shoulder replacement surgery, but the major area of focus has been kind of taking care of joints that have injuries or have developed injuries, but are not arthritic joints. They're joints often that happen as part of athletic activity or kind of active lifestyles specifically in my area in the knee, shoulder, hip, and elbow. So as you can imagine with that in mind, in terms of giving a talk a little bit on this topic, a little bit tough because it could be a 5-day seminar to talk about all those joints. So in some ways I put together some slides a little bit as a source for discussion, but we don't need to make our way through all of that. It can certainly just be an informal discussion about questions related to those things. So, you know, one of the joints that obviously I think certainly affects the aging athlete, if you will, the most is the shoulder. So I thought we could start with that. And why? Because in general, if I was to name the, you know, first, second, and third thing that I get as a complaint in the clinic, it's usually often shoulder related in the athlete, whether that be tennis or baseball or overhead sports, is shoulder pain or shoulder weakness or both. And so in general, just to kind of give some background, I put some slides you know, here together to talk a little bit about what the shoulder is. It's, you know, kind of this complex joint. You know, we all focus on the major part of it, which is the ball and the socket part between like a golf ball and a tee. But all these other joints kind of fit into it. The collarbone and the shoulder blade is part of the joint. The shoulder blade itself and the chest wall is part of the joint. So all of these different articulations, if you will, all contribute to the movement of the arm in space. And so we can get problems with any one of these portions of the joint with athletic activity, but also with wear and tear of life over time. And these can be a common presenting complaint to a doctor like myself or your primary doctor. And the anatomy of the shoulder, I don't want to belabor going through all of these things, but it's basically to show you that in terms of any evaluation for myself as a shoulder doctor or hip doctor or knee doctor or other fields of medicine, you always want to think about not just the joint itself, but everything around it that can present as shoulder pain. So, you know, things from the skin all the way deep can be sources of pain, whether that be nerves in the skin, muscles, right, like the pec muscle, which is at the chest, the pectoralis muscle, or the deltoid, which is a shoulder muscle, but kind of outside the shoulder, and then one layer deep to that, the next layer of muscles, and then ultimately all the way down to the bones themselves. And so why is that important? Because when we're evaluating or considering these issues, we always want to think about all of those things in what we would call our differential, all the things that could be causing problems. In general, as we've talked about, the younger you are, kind of the less likely it's going to be arthritis type problems. As we start to get older, there starts to be wear to the joint surfaces. But there can also be problems with the muscles, and specifically to a set of muscles that is deep to this, which is the rotator cuff. And we'll talk a little bit about that. Just for some background here, in general, at least with the shoulder joint, it's kind of an interesting joint, you know, to sort of give you a spectrum of different joints to think about. You know, each joint of our body is set up a little bit differently, right? The elbow and the knee joint are kind of like hinge joints. They kind of bend back and forth. And then the hip joint is a true ball and socket joint, but it's a deep socket. So it's a ball in a deep cup, if you will. And the shoulder kind of is somewhere in between these two. The knee is very incongruent, right? It's like a hinge that requires all these famous ligaments that we're aware of. The ACL ligament, which is a famous ligament that's torn in athletic knees. If you watch Sports Center, you often see at least once or twice a day somebody tore their ACL, whether it be basketball or soccer. And then the hip joint, which is really primarily depends upon the bony stability. The shoulder is somewhere in between. It has some critical ligaments. It's not quite as congruent as the hip. And so why is that important? Well, there's a high problem of issues with shoulder instability. And so the risk of a shoulder sliding out of place or subluxing or dislocating. And that's a common problem that we see in athletes, both young and old, depending on what kind of activities they're doing. So I thought we could talk a little bit about that potentially today. It's actually not, there's a lot of subtleties to it, but when you really kind of think about the shoulder a little bit like a golf ball on a tee, and you can see the socket is a shallow socket. It's called the glenoid, kind of big term, but it basically refers to the bony support for the shoulder, and then all these ligaments that constrain around it that kind of keep it in place. And why is that important? Well, you can kind of see here, this is kind of what your normal shoulder would do. If you're a young athlete and you're a wrestler or a soccer player or hockey player and you get checked into the boards, or somebody's wrestling and they're trying to twist your arm out of socket, the shoulder has these natural inbuilt bumpers on it. Fancy term is the labrum. But the labrum is not only a bumper that deepens the golf tee, but it attaches these critical ligaments that stabilize the joint. And you can see we're all built a little bit differently. Some people who are loose jointed, right, they're kind of hyperlax. They can do parlor tricks if you ask them to do things. They can bend their thumb back to their forearm or hyperextend their elbow. They have kind of some less kind of tension in the ligaments, easier to dislocate. And then sometimes they can be traumatic cases where the actual labrum or bumper rips away from the bone and the shoulder dislocates. These tend to be the kind that we see as athletic injuries in contact athletes, linemen in football, wrestlers for me, hockey players who get checked into the boards. But they can often happen also from repetitive microtrauma. So a baseball player or a softball player or a recreational athlete, you do a lot of overhead kind of serves or something in your tennis game. The recurrent trauma of that can gradually loosen and lax these ligaments. This is kind of all the fancy imaging that we often use to look at these things. I'm sure all of you are familiar with getting MRI studies to look into the shoulder joint. And what are we looking for here? All these fancy terms are different labels of ligaments, but the summary is basically here's the golf tee, here's the ball, and all of these different ligaments attached to the labrum around the golf tee and can be torn in various different spots, rendering the shoulder kind of unstable. So how do we treat that? Well, it turns out that once you have a shoulder dislocation, the likelihood of the shoulder coming out again is actually pretty high. It turns out the younger you are, the higher the likelihood of it redislocating. So if you're 15 years old and you present to me with a shoulder dislocation, I can now quote 100% risk that at some point again that shoulder will dislocate in the future. And as we start to get a little bit older, as joints get a little bit stiffer, capsule gets a little bit tighter, that rate goes down a little bit. And what starts to happen is rather than the shoulder dislocating again, with subsequent dislocations, you start to injure structures around the shoulder, namely the rotator cuff. So why do I bring this up as a topic in the aging athlete, if you go for the purpose of this talk, is that shoulder dislocations are kind of a universal problem, or instability of the shoulder is a problem for all ages. The only thing that changes is what tears or what gets injured. As we're younger, kind of in the under 40 population, we start to be more problems with tearing the labrum and capsule. As we're older, we have more problems with tearing of the rotator cuff. And when that happens, we often have to do this kind of surgery, which is camera or arthroscopic surgery, to fix these structures. And I often put these pictures in because I think it's sometimes the most interesting part of things that you guys don't get to see. This is with the camera what I see. This is the ball here, very magnified. This is about the diameter of a pen tip, actually, but it looks very magnified. The socket's over here, and you can see this is this bumper that should be firmly attached here to the golf tee. You can see it's kind of frayed, it's beat up. This instrument's a shaver that then cleans that. This is another case, one that I did recently in a young 18-year-old who had kind of this shoulder instability issue. Here's the golf ball. You can see it's wanting to slide out the front. And the reason for that when we put the camera in is here's the golf tee. This is this labrum that should be firmly attached to the bone here. This is my probe here. I'm able to pull the labrum right off of the golf tee. And all these ligaments that should have good tension here are kind of lax. They've been stretched out. And unfortunately, with recurrent dislocations, these ligaments aren't like a perfect rubber band. They don't stretch right back. So we sometimes have to retension them.
How big is that probe? I'm just curious.
That probe, the tip of the probe is 2 millimeters. And the width of the probe is 2 millimeters. So it's pretty small. Now, if you were to look here, this is kind of what we do in the surgery. This is the labrum. I freshen the surface of the bone here. So I'll prepare it to a healthy bleeding surface so that that labrum will stick back down, adhere down. And then this is kind of the technique. I'll actually take a device to pass around the capsule as well as the labrum here. I call it a pinch tuck, where you take a pinch of the capsule and then tuck around the labrum. And the idea behind that is not only to reattach the bumper, if you will, but to also retighten these ligaments by pinching them a little bit. And then we put in little anchors into the bone here and actually use those sutures and sew them right into the bone so you get this new bumper, as you can see, to prevent this head from sliding off the front. This is another picture of that. Why do I have it two different orientations? Because we can do these surgeries in two different positions. This is the one I tend to work in, kind of just sitting up. We do the surgery in what's called the beach chair type of position. But it shows kind of this important principle of the injury and how we treat that. And this is a very successful operation. About 90% of the time, if we do this operation and we allow people to heal and rehab, within 5 or 6 months they're back to sports. And the likelihood of redislocating changes from about 90% to around 5 to 10%. So it's quite good. But like we talked about, this is kind of the injury and kind of the spectrum of it. But this is kind of the other spectrum of it, which is what happens if we're older and we have these shoulder instability events or a trauma, right? We fall on the ice in the bad Michigan weather. I've had a few of those this winter. Or, we're on a ladder and we reach overhead and have to lift something heavy and feel a tear or trauma in the shoulder. As we get older, rather than those ligaments and labrum getting disrupted, which have gotten a little bit tighter, a little bit stiffer with age, what often gets disrupted is this thing, which is the rotator cuff. This is kind of an open picture showing that, but like we talked about, the ball and socket in and of itself would be functionless unless we had muscles to move it. And it turns out there's 4 muscles, I think I may have it on the next slide here, these 4 muscles here that are small but very, very powerful muscles that are responsible for moving the shoulder everywhere in space. They have these fancy names, the supraspinatus, infraspinatus, teres minor, and subscapularis. But frankly, you can think of them as 4 little muscles that sit around the ball and socket joint that actually are responsible for all of the movement of your arm in space. Why is that important? Well, as you can imagine, if you didn't have these muscles, you would present to me as something that we actually call pseudo-paralytic, which is a fancy term for meaning looks like paralyzed, because the person can only shrug their arm, can only shrug their neck here, is unable to move their arm. And we see that not infrequently in people who have these rotator cuff tears. They go unnoticed for some time, continue to develop pain and weakness, and then by the time they present to the doctor, they can sometimes be what we call massive tears, or big tears that are hard to repair. I don't want to kind of belabor all this and bore you with stuff, so I'll just sort of talk through some of these slides. Well, how do these rotator cuff tears happen? We talked about one of the big ones already, which is trauma, right? The shoulder slides out of place or you land on it from a fall. But there's a lot of other things that can go into it, and this is where the sporting part of it comes in. The shoulder is the rotator cuff is unfortunately an area which in the body we call it a watershed area. Fancy word for basically means an area that doesn't have a great blood supply. So, as we get older, like everything else, right, our coronary arteries start to clog, our leg arteries start to be a concern. Same thing, the blood supply to the cuff probably becomes a little bit diminished as well. So when we're young and we're 18 and we're, college pitchers playing, at the university baseball game today, we probably can get away with throwing 100 or 120 pitches and doing okay. But what happens with the recurrent overuse of 100 serves playing a 5-set match of tennis or a bunch of throws playing baseball is we start to overuse that cuff, and the normal blood supply that allows it to heal and return to function gets compromised a little bit. And so this recurrent trauma, so-called microtrauma, can also contribute to this problem of tearing of the cuff. What else? Well, there can be extrinsic things, right? Things can rub against the rotator cuff and cause them to tear. What do I mean by that? No more sophisticated than thinking about a rope that gets rubbed against a sharp stone. If there's a sharp stone there, the rope will start to abrade, right? It'll start to fray, and you'll start to see about 20, 30% of the fibers wearing. Over time, it continues to tear. Those are what we call high-grade partial thickness tears. Big medical term, but what it frankly means is nothing more than a rope that's not quite fully detached, but is well on its way there. Well, what are the things that can cause this? Let's start with talking about the anatomical thing. What is the sharp stone, if you will? Well, remember, the shoulder, like we talked about, is not just the ball and the socket, but the shoulder blade has this extension of bone here called the acromion. What is that? It's basically a piece of the shoulder blade that runs right underneath the rotator cuff. Well, this famous surgeon in New York named Dr. Neer looked at these shoulder x-rays and found that, boy, in a group of patients, they have this very prominent down-hanging, almost like a spur, like this sharp stone that would rub right underneath the rotator cuff and could potentially abrade that tendon. So patients who would lift their arm up often and say, boy, I now have a new kind of pain when I get in this position. Or when you rotate my arm in, I start to feel some soreness or discomfort there, can oftentimes be this impingement sign or impingement test, which is the spur digging into the rotator cuff causing pain. And as you can see that on a couple of different views here, you can see the spur down hanging there. And that spur can be a cause of pain. When we actually studied this, we looked and saw that in the population, we're all built a little bit differently. So these are 3 different configurations in normal patients, just all of us out there, of what our anterior shoulder blade looks like, the front of the shoulder blade looks like. And you can see some of us are lucky, right? It's a very flat morphology, meaning there's not anything down hanging to dig into the rotator cuff. Some of us may be a little bit less lucky. We have this rounded down kind of spur type of configuration that can predispose us to some problems with the rotator cuff. And that's why some people who do a lot of overhead activity may get away with that. Some of us may not. And if you look, in this study that was done by Dr. Neer, one of our famous fathers of shoulder surgery, he showed that in these people with the curved type of bone here, the incidence of a rotator cuff tear was sometimes 70%. It's pretty high. So it kind of gives us some information about that. And this is how we used to do this surgery. This is not how we do it now. But to show you the history of it, we now do it all through the camera. But you can see here, when you open it up, you can see this prominent spur here. This is the rotator cuff tendon. Here's the big hole that it's created, exposing this area of the bone. Of course, we just talked about the intrinsic factor part of it. What do I mean by that? It doesn't have to always be this kind of something rubbing against the tendon. Sometimes just overuse, right? You can start to see this is like a histology slide, which is like a microscopic picture of the cuff. You see here on this slide, there's this ever so slight starting tear that we don't see macroscopically. We don't see it to our eye, but it's starting there. And so that's, again, an injury of the aging athlete. As we get older, we strain our cuff more, and we start to develop these kind of cuff tear type of symptoms. It's called a rim rent tear. And then we talked about trauma, right? This is the classic shoulder dislocation. You can see the golf tee here. The ball should be resting here. Instead, it's slid forward and down, and that's this dislocation. And like we talked about, younger patient, you tear the labrum, and we do that labral surgery like we talked about. Older patient, this tends to result in a tear in the rotator cuff. And I should be careful about saying older. 40 is not old, but older in our population of practice is that. So this is kind of what you see. And why is this rotator cuff problem such a big deal, right? If you cut your skin or you fall, things heal, right? Our body heals. Unfortunately, the reason it's such a big deal in my world is that for whatever reason, the rotator cuff never spontaneously heals. So once it's torn, it's torn. It won't repair itself. It won't be if you put it in a sling for 8 weeks, it won't heal back. No one knows exactly why. It might be the biology of it because we talked about it. It doesn't have a great blood supply. It might also be the fact that the tendon is inside the joint, so the synovial fluid that kind of bathes the tendon doesn't really make things want to heal. So we don't know exactly why, but what we do know is once it detaches, it's always torn. And unfortunately, if you leave it torn and wait over time, the only thing it does do is get bigger. And that makes sense from a logical perspective. Why? Because remember, like we talked about, what's attached at the other end of these ropes or tendons is muscle. And if the bone lets go, think of it like tug of war, and if one side lets go, the muscle gets to keep pulling. And if you wait 6 months or a year, a 1 centimeter tear becomes a 2 centimeter tear. And then 2 years later, it may be 3 centimeter tear. And 5 or 10 years later, it may be a 5 or 6 centimeter tear. Why is that important? Well, the only reason it's important is because at some point along the spectrum of that natural history, these tears change from being reparable, meaning I can sew them back together or a surgeon can put them together, to being irreparable, meaning if you came to the surgeon and said, "Doc, can you fix this?" I might tell you, "No, I can't. That's not an option anymore." Now we're looking at more salvage type operations like replacements and things like that. So it does have some bearing on how we try to decide on when the right time is to intervene to fix these tears. Sure, yeah.
I don't know if you're going to talk about knees later, but is there a comparison to the tear in the shoulder and the comparison like meniscal tears? Is it different?
No, it's a really good question. It is different, but the principle is the same, which is meniscus tears and ACL tears or ligament tears in the knee would be a good analogy of something that doesn't heal. So those will not heal. If you have a meniscus tear, it won't heal. If you have an ACL tear, it won't heal. What is different is those tend also not to get worse, though. So if you have a meniscus tear, it can propagate and get bigger. If you have an ACL tear, it's torn, but it's not like a rotator cuff where an ACL tear gets worse. Once it's torn, it's torn. 10 years from now, it'll still be torn. The issues there are different. They relate to what you aim to go back to. If you have an ACL tear in the knee and you want to go back on a treadmill and do light jogging and walk in the neighborhood and shoot driveway basketball, is very different than a young 18, 20, or 25-year-old guy who wants to get back to college wrestling or recreational hockey, where the twisting, turning on the knee will not tolerate being ACL deficient. The one caveat to all this, and I think you brought up a good point that I should mention, is all of these things are factored in the absence of arthritis. So what do I mean by that? As a shoulder, knee, hip doctor, I take care of patients who have these problems but have not developed wear of the joint surfaces or severe wear of the joint surfaces. Why? Because once the joint surfaces are worn, once we've lost that cartilage and it's bone-on-bone arthritis or close to it, anything I do as a sports or joint preservation surgeon, unfortunately, is padding my pocketbook for the large part, but not really helping the patient. Because the ultimate problem of the arthritis is probably the most important and not one that anyone, myself or anyone in the world, at least yet, can reverse. Why? Because that cartilage that's on the end of the bones is a little bit, think of it a little bit like heart muscle. Like once what we're born with is what we have, and if you have a heart attack, that heart muscle doesn't grow back. Same thing. Once you've worn that cartilage, it doesn't grow back. And that's why these surgeries are so important to prevent that arthritis. But once the horse is out of the barn and it's there, then your better operations are not in my hands, but in my very capable colleagues' hands, who are the joint replacement surgeons for the knee and the hip, and in my case, the shoulder, but doctors who replace the joint to definitively treat the arthritis problem.
Do you always get, if you don't mind me asking a
Yeah,
question.
that's fine.
Meniscus tears, do you always get them repaired surgically?
No, that's a very good question. So meniscus tears are, it's a good question. I'll answer that by grouping them. So meniscus tears fall in two categories, a lot like everything in life, right? So there's the good young injury, right? So you're 15, 20, 25, 30, even 35, and you tore it traumatically. So yesterday, no problem. Today, played soccer. Yesterday, walked the dog. Any of these kind of twisting, turning events, and had one episode, and all of a sudden the knee is not bending, it's swollen, it catches. Those are what we would call traumatic meniscus tears. Traumatic meniscus tears in general are good ones to heal, if possible. So in those settings, no arthritis, a traumatic tear, I'll make every effort to sew it back together. Why? Because it's your shock absorber, right? So just like none of us like to drive our car with no shocks, we probably wouldn't want to walk on knees with no shocks, so we try to save it. That's a very different tear, though, than the 55-year-old with some knee pain, kind of aches and a little bit sore on the inside, didn't remember any particular traumatic thing happening, but has noticed some new pain, got an MRI, and the MRI says meniscus tear. Why are they different? Because the latter is what we would call degenerative. What do I mean by that? That means just like worn shocks in your car, if you put 50,000 miles on it, the shocks are more worn than when they have 10,000 miles. Same thing. So if you were to take 50-year-old patients, take 10 of them from Kensington Court and take them for an MRI, even with no symptoms, I would bet about 4 of them would have a meniscus tear. But it'd be pretty dishonest of me to rush them all off to the operating room to do surgery. And the reason for that is there's a high population of asymptomatic meniscus tears. So I don't worry about meniscus tears per se. They're not an operative indication for me in the older 50, 60-year-old population. Sometimes they can be symptomatic, and sometimes I'll operate on them, but if they have the right symptoms. But in and of themselves, they're very different than the one-time kind of traumatic tear. That's kind of the short answer of it, if that sort of...
Can I just ask further?
Yeah.
What about a traumatic tear in the 50 or 60-year-old person? So there is a specific traumatic event, but it's not the younger person.
It's a great question. So if it's a traumatic tear and there's minimal arthritis in the joint and the tear pattern looks repairable and it has a good blood supply, I don't condemn the patient because they're 50 or 60. My parents are that age or a little older. They wouldn't like me for that. So you have to still just treat it by what you see. Now, on the other hand, if the joint has arthritis in any of these surgeries, if the joint has wear, if it already looks like the tear is shredded, it doesn't have a good blood supply, often the better treatment for the patient is to just resect the torn piece. Why do I say that? Not because anyone wants to lose shock absorber, but nothing is worse than repairing a tear that you know is doomed to failure, rehabbing it for 6 months, and then 6 months later the patient goes for their first forehand of tennis or walk and says, look, it happened again, and now 6 months later I did all of this and you're telling me we have to trim it anyway. So part of it is always a game time decision on the quality of the tissue, the blood supply, what the symptoms are. But the short answer is if the patient doesn't have the arthritis and has a traumatic tear, there's no reason you can't fix it in a 50-some-year-old.
Those questions are answered with the MRI?
Somewhat with the MRI, but most on game day. So mostly at the time of surgery when you put the camera on the joint.
See what's actually in there.
Yeah, and why is that? Because MRIs are good, they're not perfect. So they're about 90% effective at telling us that there is a tear. What they are not effective at is telling us what type of tear. Is it shredded tissue? Is it good tissue? Does it have a blood supply? Does it not? If I probe it, will it hold a stitch? Is it shredded and won't hold a stitch? Those kind of things.
Blood supply is partly due to location?
Absolutely, yeah. The peripheral third of the meniscus, if you have tears in the outer part, it's good news for you. If you have tears on the inside, not so good news. And of course, like everything in life, right, a little bit younger, a little bit more blood supply, a little bit older, a little bit less. So in general, older people tend to have degenerative tears, so we tend to repair them less. But in the isolated case of a traumatic tear with no problems, absolutely repairable. I did one recently last week. Now, the most important thing to remember, too, is sometimes these injuries don't happen in isolation, right? Meniscus tears usually happen with something else, and oftentimes that something else is an ACL tear or a tear of a ligament in the knee. The good news about that is when you add on the ligament injury, the likelihood of that healing goes up. So doing both surgeries together, probably from the blood in the knee and the trauma from surgery, creates a nice healing environment to make things heal. So I'm very aggressive about repairing meniscus tears when they happen as part of a bigger injury to the knee.
I read a lot about the red zone and white zone. Is that something you tell just by doing surgery, or is that?
No, so that's a fancy term, but that is referring to exactly what we just talked about, which is the outside of the meniscus is the red zone. What does that mean? That means if there's ever a spot that's going to have a good blood supply, it's that outer third of the meniscus. Then there's the red-white zone, which is the equivalent of what you might call the controversial zone, meaning if I fix it, it might work. If I fix it, it might not, because it has some blood supply, but jury's out. And then the white zone, which is the inner zone, that's the inner third of the meniscus that will not heal.
So how do you tell that on the MRI?
You know that at the time of surgery, but you also can see on the MRI to some degree the location of the tear. What you can't tell is what pattern, right? Is it shredded? We have all these different terms, radial tears, peripheral tears, cleavage tears, and some are repairable, some aren't. No problem. Feel free. That's sort of the idea here is to stimulate that. And then, this is kind of just some more just showing these issues. And here's the issue, which is, I think, a good question to ask is, just like you brought up with the meniscus, what do we do about these rotator cuff tears? Do I rush everybody off to the operating room and say, look, you've got a cuff tear, more surgery for me, let's go do that? No, that's not how we operate. Hopefully not. Certainly not in my department. And why is that important? Because some people have these rotator cuff tears, right, and are asymptomatic, meaning, if I took an MRI of 10 people in the lobby who had no shoulder pain, it's possible that 1, 2, or 3 of them have a rotator cuff tear. But the reason for the difference is some people are good compensators and some aren't. What do I mean by that? If the cuff tear happens over time, right, it's a gradual process, the body is smart and it will use other muscles like the deltoid muscle or the pec muscle to compensate, meaning to allow you to cheat, if you will, to still move the arm around, just not using your rotator cuff. So that's why sometimes these tears present to us, unfortunately, late, because patients who are very good compensators will get by with day-to-day life and be able to do things using other muscles. Other times we're less good compensators. Maybe we're a little bit less athletic. We haven't been as conditioned or toned, and so a small tear is much more symptomatic in us than somebody who's maintained a high level of shoulder strength and function and can get away with one of the 4 tendons kind of being disrupted. So that's kind of the issue, is multiple factors play into it. Sometimes it's related to the inflammation. Sometimes it's related to trauma. Sometimes it's related for the ability of the patient to compensate. But all of those things go into it. And so when you really look at which of these cuff tears need to be fixed and which don't, it depends on the ability of the patient to compensate and how much they tolerate pain, right? Some have a higher threshold than others. So in terms of the ultimate question here, if you have one of these rotator cuff tears, this is what it looks like through the camera. Here's the ball here. This is the tendon. It should be attached down to the bone here. Should I leave it alone or should I fix it? And I think the answer is it's a little bit of a tightrope, like most things in medicine. There's no 100% right or 100% wrong, and it's a balance, right? So the balance is we don't fix all of them, right? We don't take everybody to the operating room who has an MRI finding to surgery. Why? Because then I'm treating MRIs and not patients. That's not honest. On the other hand, I probably don't want to tell all patients with big rotator cuff tears to go have steroid injections and see me in 5 years. Why? Because 5 years later, if this tear has become so big, I've done the patient a disservice by not repairing it when it was repairable. So it's a little bit of a tightrope of monitoring the tear to make sure that it hasn't become so large that it's irreparable, but on the other hand, hopefully finding the appropriate symptoms to make sure that I'll reliably make the patient better.
As the tear got larger, would that be accompanied by pain so that the patient might know that?
It's a good question. Typically it is, and usually by weakness. So usually you start to notice things that were a bit easier to do, raising your hand overhead, particularly moving your arm at the side here, rotating outward. You'll notice some weakness and some pain. And that's typically when you've sort of lost your compensatory function. Some of these other muscles you were using to cheat. And why, again, like I pointed out here, why is this important? Because a repair like this from a recent picture in the operating room, easy for me to fix, right? I can stretch the tendon back. This is through the camera. I've prepared the bone right where it should go, and we sew it right down to the bone with these anchors. But what about something like this? You know, in this case, the tear was bigger. I had to use a bunch of side-to-side stitches to get it back together first and then sew it back to the bone. But eventually, these tears can get so big, like this patient, where I put the camera in and look, here's the ball, here's the socket, and the rotator cuff is retracted all the way back here. Why is that important? Because even if I pull with all my might or I release all the scar tissue here and try to stretch this back, that's never coming back. And that's important because this is no longer the type of surgery that would be fixed by sewing the rotator cuff. In this case, we have to start to look to some of these other things. So this is that patient. This is showing the importance of catching these injuries. You can see here, if we let it go over time, when you lose the rotator cuff, here's the sharp stone. You guys see that here? The ball has now slid up all the way against that sharp stone because there's no tendon in between. This is a fancy term for rotator cuff arthropathy. Frankly means arthritis secondary to lacking a rotator cuff. The rotator cuff is gone. And this is no longer one that you would fix by fixing the surgery. This is one that requires operations like this, where I have to replace the ball with metal, replace it here with a special type of implant called a reverse shoulder replacement, where I frankly put the ball on the socket and the socket on the ball side. We reverse everything, and that's a way of allowing you to function somewhat like you have a rotator cuff. But again, these are no longer the athletic sports operations. These now become the salvage operations for day-to-day life. Brushing your teeth, combing your hair, bringing food to your mouth. No longer for trying to hit a Pete Sampras type of tennis serve or something like that. And what about this? This is also for the younger patient. So what do you do for the 30-year-old who has a massive cuff tear, right? They had a traumatic injury, car accident when they were 15 or 20, ignored the shoulder problem. Well, in that patient, it wouldn't be a good idea for me to replace the shoulder with metal and or plastic. So then sometimes I have to do this kind of operation, which is a salvage of a muscle transfer, where I frankly move a different muscle in the body to act like the rotator cuff, kind of trick the body into using it like a cuff. Again, big operations. These are salvage operations for the patient that has that. And this is another very important point. Why do I put this up here? Because right now, as I've talked to you all about this, we've talked only about the fact of, can I repair the tendon to the bone, right? So physically, can we stretch it there? The part we forget about often is that what's attached to that tendon is muscle. And that muscle sits here, and it goes on vacation when there's a tear, right? It doesn't have to work because it's detached from the bone. And things like vacation, right, we all do. But when the muscle goes on vacation, what does it do? It gets small, right? It atrophies. And if you have any question about that, put your arm in a cast or your leg in a cast for just a week and watch what happens to the diameter of your thigh or your arm. It shrinks phenomenally fast. And the reason for that is disuse of the muscle results in profound shrinking or atrophy. The problem is, in the case of the rotator cuff, is once it shrinks down like this, it fills in with fat. Fat is white on the MRI. It should look like this, nice, black, healthy muscle. Here it's white. And once it becomes fat, it doesn't turn back. So even if I sew it back to the bone, it's functionally useless because the muscle that's attached to it will no longer come to work. So that's important. Again, another reason why we want to catch these injuries early. So we talked about this tightrope analogy, right? Which ones should we do here? Well, we don't want to treat them all non-operatively because we're not helping people. We don't want to operate on all of them because then I'm just padding my pocketbook. So we probably want to be somewhere in between, right? We probably want to do the right thing for patients. And these are kind of some of the tests to get at those kind of points. I'm going to breeze through there a little bit because I think I want to show you a little bit about the repair. So how do we do this surgery? I think we talked a little bit about this. This is how we used to do this surgery. This is the classic way that most surgery is done, right? Open. What do I mean by that? We make an incision. We have to split the deltoid muscle, which is the big muscle surrounding the shoulder joint. And then we would get down below to see the rotator cuff and sew it. I put this picture down here because this is the analogy that somebody else brought up with regard to the knee. When you have these ligament injuries in the knee, this is what we used to do. We used to cut the knee open, slide the kneecap out of the way, and here's an ACL ligament that we're sliding into place. Well, look at what's changed over the past 10 or 15 years. in a phenomenally good way for our field, is this is now the exception rather than the rule. There are still rare cases of massive tears where we have to open the shoulder, but for the most part it can be done this way, with a few poke holes that allow for some cannulas to go into the shoulder. We inflate the shoulder with water, with basically saline, which is salt water, and that allows us to do work and to safely move instruments without scraping the joint surfaces. Same thing here, you can see this whole ACL ligament has gone into the knee all through the camera. It's also magnified, gives us very kind of high definition pictures. And this is kind of how we do it, how I do it in the operating room. You sit just like this in a beach chair. I can often do the surgery under sedation with what's called a block, which is where our very good anesthesia team just numbs up the arm and shoulder so you don't feel anything. And you just kind of sleep here while we do the surgery. This is kind of just showing how I do that. This is the shoulder blade. We make some marks here on where we would go. And this is kind of what you would see. This is the goal here. When we've marked out these things, we know where all of these tendons should be attaching to along the edge of the ball. And this is kind of what we aim for here. We prepare these same areas to healthy bleeding bone. We put these anchors into the bone, and we sew the tendon back to the bone. And I'll sort of walk you through those steps here a little bit. This is kind of what I initially see when you go into the shoulder joint. You put the camera in. Of course, because we're there, just like if we're in the knee or the elbow or hip or any other joint, it's always good to be thorough, right, to inspect everything while you're there. This is the golf tee. You can see this is covered in a younger patient. Nice, healthy cartilage, nice and white. This is that labrum. You can see it has a little bit of fraying, a little bit beat up, but nothing too bad, not detached like that other pictures I showed you. This is another tendon called the biceps tendon that lives up top here that looks healthy. So we inspect everything. Here you can see I'm pulling the biceps tendon into the joint. Again, a little bit older patient. You see a little bit of damage here to this biceps tendon. Doesn't look totally healthy. Certainly could be a source of pain. Why is that important? Because in somebody with something like that, you might want to make sure that you address the biceps tendon. Then you can see when I start to look a little bit at the ball, I can get a sense here that something isn't quite right? We shouldn't have all this pink, unhappy tissue here. Anytime in general, orthopedists aren't necessarily that smart, so things that are red are bad, right? So you use that as a guide. So if I see red, I'm usually worried. And then what we look for is I put the camera up above, and lo and behold, look at this thing here. This is that bone spur we talked about, right? This sharp stone. You can see this is the undersurface of it. It looks worn and abraded, like it's been rubbing for something, against something for quite a while. And then you can see when we kind of unroof that, we start to say, okay, maybe it's one of these type 3 type of acromions, and sure enough it was. So I shaved all of that away so you can see all of a sudden there's a whole lot more room now for the shoulder to do its work. And then when we turn the eyes of the camera down, you see this, right? You shouldn't see that. I shouldn't be able to look into the joint, right? Because the rotator cuff should be in the way. And this whole big U shape of tendon here should be attached right back down to the bone here, which is where that redness was that we saw from the inside. So how do we fix that? Well, we'll show you that here. We move the camera to a different location. Just like we did with the bone spur, we'll prepare all of this to healthy bleeding bone like that. That's what healthy bone looks like, this yellowish color with some bleeding pores there. And then we put these anchors into the bone. Again, all done percutaneously. We can put a needle in to make sure we're at the right trajectory. Then one of these anchors comes in like this. It's like a little screw. This happens to be made of inert plastic with some sutures that are attached to it. We screw those into the bone here like that, and then pass the sutures in and around the tendon here, and do that on as many as are needed, and sew things down to the bone here by tying some knots through the cannula. So you can see that nicely repairs things, brings the tendon right against that bone, and then Mother Nature kind of has to let that heal. This is a different view of that. This is the way we do these repair now. They have a fancy term called a double row repair. What does that mean? It basically means that we're making a single row of sutures medially and then a second row of sutures laterally, so this whole square of tendon is directly stuck against the bone in a watertight way. So it can directly, the bone can grow into the tendon and kind of make it back to one. That's kind of the shoulder stuff. I obviously have more pictures and lots of other things, but I thought we'd kind of keep it briefer that way and leave it open for specific questions. Hamid?
If you drive a stick shift, you shoulder more or transition?
Can that make your shoulder worse? Any repetitive activity can certainly do that. Stick shift might be one of them. In general, activities that are done away from the body. So, things that are close to the body tend to be the best for the shoulder. So curls, seated rows, lat pull downs, those tend to be good exercises. Why? Because you can imagine they're close to the body, so the lever arm on your rotator cuff is short. when you do things away from the body, so-called fly exercises or multi-directionals or things that sometimes people who are training athletic competition, imagine, I'm certainly not the largest guy, but even your arm length is 2-3 feet, and that multiplied by whatever weight you have in your arm can be seen as a lot of weight on the shoulder. So even 10 pounds here with the lever arm can be 100 pounds for the shoulder. So in general, it's safe to do things close to me, but farther away things are a little bit harder, and any repetitive activity could strain the cuff.
Question. I'm a physical therapist, and I got a patient who's about 55 who is stuck on push-ups. Mm-hmm. He has a history of a traumatic rotator cuff injury on the right. He's got apparent rotator cuff tendonitis on the left. I'm telling him you should knock off the push-ups. If you do anything, bring your hands in versus spreading them out. Any advice on that? That's the one thing. And the other thing is special tests for differentiating diagnosis with rotator cuff. Yeah,
so both good questions. I'll start with the first one. So I agree with you completely. Push-ups are a little bit of like a cheap man's military press, right? So it's essentially a bench press that you're benching your body weight. So that can be pretty strenuous on the shoulder. I worry about it a lot in people with instability, right, because it can push the shoulder out the back. It's not wrong to do push-ups with a cuff tear or with cuff problems, but like you said, if you bring things in, it will stress the shoulder less than being out. In general, though, for cuff strengthening exercises, it's kind of a little bit counterintuitive, but you're best off doing lower weight or lower resistance and more repetition. So tubing exercises for the external internal rotation are better to strengthen the cuff than any push-up is. The number one muscle that you're using with a push-up or press is the pec. So those exercises would be effective for that gentleman in strengthening his pec and maybe strengthening some of his deltoid depending on where he puts his arms. But to really strengthen the cuff and his shoulder blade or scapula, he's really going to be best off doing the tubing exercises, starting with a low resistance tubing, I think like green, and then progressing as you go up to the red tubing, and then shoulder blade exercises. So scapular pinches, even the shoulder blade kind of bear hug type of exercises can be good for the rhomboids, the scapular stabilizers. Because remember, the shoulder requires not just the cuff to work, but for the golf tee to be straight, if you will. If the golf tee is tilted because the shoulder blade is protracted or a kind of hunchback posture, I'm the worst example of that, but those kind of posture problems will create problems for the shoulder. So I think you're on the right track on kind of downplaying those exercises and sticking more to close to the body, isometric kind of exercises with tubing.
And special tests?
Yeah, so special tests, special tests for the rotator cuff. The good thing about the rotator cuff is that it's a little bit sensitive. The most sensitive thing would be weakness. So when you have the arm up at the side, your thumb down, that tests the supraspinatus muscle. Thumb up might isolate infraspinatus a little bit more. One of the easiest tests is to have people put their arms down at their side and have them resist you as you do external rotation or resist them. Weakness with external rotation is a remarkably sensitive sign for cuff weakness. Why is that? Because of our 4 rotator cuff tendons, 3 of them are external rotators and only 1 is an internal rotator. So weakness with external rotation is pretty sensitive. All the other tests, unfortunately, which is just pain with raising your hand, pain along the shoulder, along the joint line, is sensitive but remarkably not specific. What do I mean by that? It could be impingement, it could be a frozen shoulder, it could be an unstable shoulder. There's a lot of things it could be, and so that's where the physical exam testing of strength helps and MRIs help, or ultrasounds.
Could you talk about, when I was here, I played a lot of tennis. When I moved to St. Paul, I started playing a lot of squash. Mm-hmm. And in the squash, a lot of the players trying to play at the elite level develop a problem with the pec muscle and the shoulder muscle in that short snap. Have you seen that in racket sports players here?
Yeah, it's pretty common. So what you're saying is totally true. All those overhead sports, which include, in my world, not only baseball and softball, but javelin throwers and tennis players, tend to develop problems with not just the pec, as you mentioned, but the biceps tendon in the front. And it has a little bit to do with the fact that, to give kind of a short anatomy lesson, the biceps, bi meaning 2. So there's the long head of the biceps, which actually goes right into the shoulder, and then a second head of the muscle that inserts here in the chest. And the tendon that goes into the shoulder, as you can imagine, because it's in the shoulder joint, when we do some of these overhead motions, can actually get pinched, irritated, and inflamed, and it causes a tendonitis that hurts in the front of the shoulder. And that's not uncommon. It's usually initially treated with a period of rest, therapy, to avoid those overhead positions, sometimes an injection right here into the groove to calm down the tendon. And only when all of those things have failed us, then we talk about surgery for that, which is actually a simple operation. You actually saw a damaged biceps tendon in the picture there that we pulled in. We simply cut the tendon, and because you have the other redundant tendon in the chest, we get away with that. So that's called a tenotomy procedure for a biceps. Sometimes people who are cosmetically concerned about that, they don't want the look of a muscle bulge here, will sometimes sew it back down to the bone, do what's called a tenodesis. But that can be a very effective operation. Sometimes they happen in young people. I've recently operated on a pitcher who, you don't usually think you'd have to do these operations in 20 to 30-year-old people, but sometimes with the recurrent repeat activity, it can be a problem.
Back to your comments about doing push-ups and keeping things close in. Could you make any similar comments about dealing with knee pain, strengthening the muscles around the knee joint?
Yeah, it's a really good question. Yeah, very good question, and probably a hard one to answer shortly. I'll try to be somewhat brief about it, but that obviously depends a lot about the problem. In general, I'll group them into kind of big categories. So the patellofemoral joint or the kneecap joint in the front is one that we see a lot. People who have worn, kind of surface under the kneecap will have anterior knee pain or pain in the front of the knee. Tends to be a problem that you've experienced going up and down stairs, right? It's hard because that relies a lot on your quadricep muscle, which as you push your weight up or come down will stress the kneecap. So that's a joint that benefits a lot from quadriceps strengthening and strengthening of the muscles. So things like leg press in that case, which can be a good exercise to strengthen the quadriceps, can work very well. What's a bad exercise? Well, things that are going to aggravate the kneecap. So a stair stepper is probably not a good exercise. Resisted leg extension, where you're pushing weight away as you straighten your knee, probably not a good exercise. So in general, I think the best exercises that are easy on the knee are going to be non-weight-bearing exercises like ellipticals, cycles, swimming, spinning, that can allow you to generate resisted muscle force but don't have the pounding on them of running or jogging or those kind of things. And then the things you really want to stay away from in general as you're rehabbing the knee, things like heavy squats that can stress the joints in kind of deep flexion positions.
How about knee flexion with resistance, pulling?
Those are good exercises for the hamstrings, and I think those are very good. So hamstring curls are what those are called, and those are very appropriate. So I think in general, like you're saying, you want to balance your strengthening for any joint, right? You don't want to just be somebody who's got big biceps and no triceps, right? Kind of same idea. So you want to always do a balanced muscle exercise protocol, and that's a good way to do it. I think there was a hand up here that I've been skipping for a bit.
Yeah, how about supports for knees for things like golf?
Yeah, it's a really good question. So I think the question is bracing. Is there any role for bracing? And that's a tough question because I'll answer it kind of generally. So the short answer is braces in general haven't been proven to do a lot for the unstable knee. So if you have an ACL tear and the knee feels loose or sloppy, wearing a brace might make you feel good, but in terms of preventing an injury, not so great. So you can't get an ACL tear, slap a brace on, go skiing, and hope that the knee is okay for skiing. Now that being said, it is protective sometimes against injuries to the inside ligament, the medial collateral ligament. That's why if you watch football players on ESPN, all the linemen are wearing those braces to protect against that injury. Now the other sleeves, though, like the neoprene sleeves or kind of over-the-counter braces, they can be helpful in terms of generally aligning the kneecap, kind of providing a little bit of soft tissue stability around the knee joint to make it feel comfortable. There's very little downside to using them, but I don't know necessarily that there's a lot of science that we have to back it up. There is one special type of brace that's called an unloader brace, which is a very effective brace, and that's specifically meant for somebody that has arthritis on one side of the knee or the other. And what do I mean by that? So if you're bow-legged and all of the weight is going on the inside of the knee, it's a brace that kicks you out and makes you knock-kneed. And if you're knock-kneed and all the weight is going on the outside of the knee, it kicks you into being bow-legged. So it can be effective in terms of unloading the bad part of the knee, if you will.
What's that called?
An unloader brace.
Unloader brace, is that name?
I'm sorry?
What's the name of that?
An unloader brace.
Okay, I got a problem that I went to the university and they checked my knee and I got like, it's always paining me. So they take all the X-ray, and they say I got to put in what you call it, the joint. It's a little separate, so they say I got two things. Either I reduce to see if my knee gets good, or they want to put in a platen or something like that.
I'll put in a replacement, a partial replacement. Yeah, that's along those same lines, which are the idea being that if you have wear in one portion of the knee joint, the brace can be very helpful to see if the brace is helpful to you, meaning by unloading that area, it feels much better, then you might be a candidate for one of these operations that, like the partial knee replacement, which simulates the effect of the brace permanently. So think of it a little bit like a permanent internal brace.
Well, they give me an injection and say that injection might do me a little good. Is that injection any?
Well, so good question. So it depends on what was injected. In general, in our world, injections are in kind of lots of different groups, but the most common one, right, 90% of the time if someone told you they had a joint injection, it's steroid injection. And what is steroid? The best way I describe it to patients is think of it like 400 Motrin that I took and tucked right into the joint. So that's a little bit of what it is. It's a very, very powerful anti-inflammatory. So if you took like 400 pills and tucked them right into the shoulder, I assure you whatever's hurting in there will feel good. And it's the same thing with the knee joint. So if we put those 400 Motrin in the knee, it'll feel good, but it's a little bit of a Band-Aid. So you have to understand that it doesn't treat the underlying problem. It buys time. So for example, if you said, you know, Doc, I know I have this terrible meniscus tear, but my daughter is getting married next week, and I want to walk down the aisle, that's a perfect indication for a steroid because it'll buy time. You know, you'll feel good. It'll let you walk without discomfort. And then down the road, as predicted, 2 or 3 months, you'll say, things wore off, I'm back where I were. Now, steroid injections are not perfect, but they are a reasonable kind of treatment. In your case, probably a good way for them to get a sense if the knee joint in general was causing the problem, and then for them to kind of sub-focus on what area of the knee was the problem.
I got a problem that I got to be going upstairs and come down. My bedroom is upstairs. So, what sport good? Swimming?
Yeah, so that sounds like kneecap problems with stairs. So swimming is very good, but probably the best is cycling. You know, cycling on low resistance is a very good exercise for strengthening the muscles. Biking. Yeah, like an exercise bike or an elliptical. Those would be good exercises.
Thank you.
No. Okay.
What is subluxation? Shoulder subluxation?
Yeah, that's a fancy term. That actually is what we talked a little bit about. That's a fancy term for a shoulder that almost dislocated but didn't quite make it. So it's like it slid out of place 80% of the way but slid back.
And it's progressive? It gets worse? I have to go back every year for a checkup.
Yeah, so once, it's like we talked about, you can think of it a little bit similar to the dislocation. So once you have a subluxation event, you are predisposed to having it, a higher risk of having it again. But like we said, it depends on when you had it. So if you're 50 or 60 or mid-40s and had it, maybe 30-40% chance that it'll recur. If you were 20 when it subluxed, then probably 80-90% chance it'll happen again, which is the reason for the periodic checkups. But it's nothing more than one of these episodes where it slid out of place traumatically or otherwise, and then kind of, you're sort of at risk for it happening again. Oh, sorry, go ahead. Yeah.
I have a couple questions, about the shoulder. If you have tendonitis and you're doing home exercises from physical, if it hurts, should you be doing it? I get mixed. That's one point. The other thing is about the knee. I had a meniscal tear and I had to stop doing aerobics. Between seeing my doctor and seeing orthopedic doctor, I can't do anything, and it's just about killing me. But I'm just wondering about that.
Yeah,
do you have anything that hurts? Are you, like exercises, are you supposed to stop?
Well, that's a very good question. So, and the unfortunate short answer to that is that it depends. And what do I mean by that? So for example, a frozen shoulder is an inflamed shoulder where anytime you move it, it's stiff and it hurts. But in fact, the treatment is to push through that and to move it a lot. So you push through that pain and push through that inflammation to get your motion back. That's a very different problem than a rotator cuff tendonitis or periodic inflammation where I might tell you, no, I want you to rest the shoulder and allow the rotator cuff tendon to heal. So it depends on the diagnosis.
Tendonitis is more kind of a rest.
Yeah, generally it's a rest followed by strength. In general, for most tendonitis, whether it be patellar tendonitis of the knee or the rotator cuff or hamstrings, is usually going to be 3 stages. It's going to be rest, allowing things to heal, followed by range of motion to get your motion back, followed by strengthening. And there'll be all kinds of exercises that will make it seemingly complicated. But in general, it'll always be those kind of phases, rest followed by motion, followed by strengthening. And if you stick to those guidelines, generally you're safe.
When you show reattaching the rotator cuff, how long does it take for that ligament to attach back into the bone? Can you?
That's a very good question. So that's the hard part with all of the work that I do as a sports surgeon or shoulder surgeon is day 0 when I sew it back is 1/3 the battle, and 2/3 the battle is A, the patient or the athlete doing great rehab and working hard, but B, getting it to heal. In general, these things take about 6 months to heal. Why is that important? Because those are magic numbers that people will give you when they say, I tore my ACL, doc, when can I get back to wrestling? Or when can I get back to hockey? And I say 6 months, and then they pout or are unhappy. And the reason for that isn't because 6 months is a magic number. It's because in general, it takes about that long for Mother Nature for the bone to heal into the tendon. And that's not everybody, right? Some people are 9 months, some are 4 months. And so we're progressive about how their knee looks and feels or their shoulder looks and feels. But in general, you can count on that. So if you have a full thickness rotator cuff tear, probably 5 or 6 months before it started to heal pretty well, more like a year before it's probably solidly healed to bone. That number changes on how big the tear is. So big tears, because there's a lot more tension on the repair as you've stretched it back, less likely to heal as fast as a small 1 centimeter tear that might heal in 2 or 3 months.
Can you put any type of like a growth factor in there that will speed that up, or do you? Or?
That's also a very good question. That you should start writing some NIH grants because the whole world is searching for that. That's a billion-dollar industry in my world, and the whole world, we're all searching for it. I certainly have some active protocols on what to deliver there. The short answer is there's lots been tried. The real answer is none have panned out perfect yet. The one that's the most exciting or that you'll read about if you open the newspaper is something called PRP or platelet-rich plasma. Heinz Ward got it during the Super Bowl, and so that kind of created this stir. But what it really is it's your own blood actually spun down, and you take all the good part of your blood, if you will, and you tuck it right where you're repairing things. And the thought is that by taking all of those good humors, if you will, it kind of heals. But again, the data to support it has been lagging behind the industry promoting it for obvious reasons. So,
what are the preferred drugs for just ordinary shoulder and knee pain?
Like pain or like arthritis, or depends on what it is. But if it's arthritis, in general, it's going to be anti-inflammatory. So, not narcotic medication, as you know, because that's certainly more meant for post-operative or acute traumatic pain. And there's no one better brand than the other. In general, I will tell you things like naproxen, which is Aleve, I think, and Indocin. They're pretty strong, pretty powerful. Things like Motrin, which is ibuprofen, a little bit weaker. So it depends on a balance of what your stomach can tolerate, what medical contraindications you may have. But all of those medications would be safe and reasonable. Dr. O, we have one of our faculty here, urology faculty.
What's the current view on microfracture surgery for bare joint surfaces?
That's a good question. So what Dr. O is referring to is, there's the arthritic knee, right, which is the knee that the whole cartilage is worn, gone away. And then there's knees where the joint is actually great, and there's a small pothole. So think of it like a pothole in a newly paved road, right? The road looks perfect, but there's that one spot that's lacking cartilage. So microfracture surgery is still considered to be among kind of gold standard surgery, but it's meant for small cartilage defects. So ones that are smaller, in my opinion, than about 1.5 centimeters squared are amenable to microfracture. The problem is that microfracture, and what that is basically drilling holes into the bone, and then the stem cells from the bone marrow fill in the pothole and mature into a clot, and then that clot sort of matures into cartilage, or hyaline-like cartilage, kind of similar to cartilage. The drawback is it depends on the surface, so patellar defects work less well if it's on the kneecap. If it's on the weight-bearing condyle of the femur, works pretty well. Has to be a well-shouldered lesion, has to have kind of good shoulder so it can fill in like a pothole. If it's eroded on the side or doesn't have good margins, doesn't work so well. I use microfracture surgery as a primary line surgery for a small cartilage defect. If it's a bigger defect, then I would recommend some other type of operations like cartilage transplantation from either your own cells that have been grown up in the lab, what we call ACI, or even transplanting blocks of cartilage from a non-important part of the knee to an important part of the knee called mosaicplasty, where we take little pieces of cartilage and move them around. Microfracture surgery, the other things to know about the outcomes of that, the older you are, the less well it works in general. And the major outcome, it turns out, is fill of the lesion. So if we were to do a microfracture, we would hope that it would fill in with blood clot. And what we've shown is if we take an MRI 6 months later, if it filled in real well, and like 80–90% of the lesion filled in, you'll have a great result, no pain. If only 2/3 or 1/3 of the lesion filled in, won't do so well. And all that has to do, I think, with how well shouldered it is and what surface it's on. I don't know if that sort of answered the question, but generally.
Could you comment on glucosamine and chondroitin supplements?
Yeah, good question. Again, another one of these areas. The good news about glucosamine and chondroitin, not a lot of downside. There are some side effects, but they're usually pretty minimal. I think they're mainly some bleeding side effects, but kind of just increases your bleeding a little bit. The drawback is that I would probably say, if you were to quote numbers, probably around 50-50. So 50% of patients who take it would say, definitely helped, I feel better with it. 50% would say, not sure, made a difference, but I took it. So I think the good news about that is that if you have mild to moderate arthritis, certainly not arthritis that you would go off and have a knee replacement or a hip replacement, is little downside to it, because if it works, great. If it doesn't, you haven't really burned any bridges. And I feel similarly about injectable forms of that. So things like Synvisc or Orthovisc, or these are things that are hyaluronic acid based. Think of them a little bit like what I tell patients, which is motor oil for the knee. It's a lubricant, kind of loosens things up, makes things a little smooth. Some patients, 40–50% have it, say, swear by it, so happy I did it. Others say, not a lot of relief, but again, little downside.
Do you have patients who present with just pain in the joint that's just very specific, localized at the tendon, where the tendon attaches, and does not affect the rest of the joints?
Yeah, absolutely. We see that quite commonly. Jumper's knee is a good example of that. So basketball players and hurdlers and track athletes will often come in with patellar tendonitis, where there's one spot on the bottom of the kneecap. It's inflamed. You push on it right there, it hurts. Rest of the joint is totally normal. We see it in Achilles tendonitis often. You push right on the Achilles tendon. Hamstring tendonitis, they have no pain in the knee, but right on the back of the knee you push on their biceps tendon. And so that's not uncommon. The good news about it is that usually you can distinguish it from a joint problem by no effusion. So the joint itself won't be swollen, and that helps to distinguish it as being outside the joint problem. So the patellar tendon runs right in front of the joint, but it's not in the joint. And the hamstrings run right behind the joint, but they're not in the joint. So that helps.
What is it? Tylenol, aspirin?
Anti-inflammatory. So you want to, again, treat it like a tendonitis. So you want to get the inflammation down, avoid whatever the exacerbating activity is. So for example, if it's patellar tendonitis, it's usually eccentric loading with jumps. So hurdlers have to stop hurdling. Basketball players have to stop taking jump shots. Track athletes have to stop, knee-high kind of exercises. Rest and anti-inflammatories, then gradual stretching of the tendon, and then back to strengthening as the last phase of it. And then there's other things. Again, if those things don't work, then we think about injections and stimulating the area to try to get it to heal. For example, this PRP might be a good indication for tendonitis, where we can inject these good humors and try to get the tendon to heal.
There's a lot of talk about vitamin D3. Is it any good for joints?
Vitamin
D. Vitamin D.
Oh, vitamin D. There's a lot of talk about vitamin D for a lot of good things. Vitamin D seems to have some favorable effect in my world on muscle. So it might help muscle recovery. So keeping good levels of vitamin D are good for your bones, for bone health, but also for muscle. There's no specific data to say that it protects joints per se or cartilage, but I would always recommend a glass of milk or two. So.
Can I ask specifically about ACL repair again? And how good does that surgery work? I don't know how well does it? If it doesn't work, what about a re-repair?
Yeah, it's a really good question. So ACL surgery, it's probably the most common operation I do, being honest with you. I did 2 today. We do it about 5. In sports practice, it can be as often as 5 or 6 times a week. And why do I do it so often? 1, it's a common injury in young athletes. But 2, is probably one of the most reliably good operations I have in terms of expectation. So I would tell you in my practice, 90-some percent, 95% chance or higher, you'll have a good outcome to be able to return to the sport at the previous level of competition. So if you were a professional athlete, you should be able to get back to pro sports, again, barring other injuries in the knee that might change the outcome. So it turns out if you have an ACL tear and a meniscus injury, I'm more worried about your long-term with the meniscus injury than I am the ACL tear. Because again, losing the shock absorber is more worrisome to me and something that I can't undo if it's an irreparable meniscus tear than reconstructing the ligament. Now that being said, ACL surgery is a little bit of a specialized surgery, should be done, in my opinion, by an experienced either sports fellowship trained surgeon or arthroscopic surgeon. Why? Because there's a number of different reasons why an ACL surgery would fail. In general, there are 3 categories. So one is technical, meaning I as the surgeon did a bad job for you. I didn't put the tendon back or the ligament back in the right spot is the number one error, is I drilled holes which weren't where the ligament used to be. Or I didn't fix the graft right, I didn't fix it under good tension, or I didn't do appropriate things to allow that ligament to function normally. The number 2 reason is biology, meaning I put in a graft and you just didn't heal it, which can happen. Usually that happens more commonly with donor tendon. So what do I mean by that? We didn't use a piece of your own tissue, we used donor tendon. What's the advantage? It doesn't hurt, right? Because I can take donor tissue and it's available in mass quantities. The drawback is it's not your own, so it probably takes a little longer to heal and incorporate. And then the third is trauma, which is we did a great surgery, you healed well, but 3 months after the surgery, you fell on it. Or 3 months after the surgery, you were doing physical therapy and the therapist cranked on the knee real hard, or you went back to sports at 3 months instead of 6 months when I cautioned you against that. So those are kind of the general categories of when they fail. And it'll still happen. I still have occasional failures, and usually you try to find an explanation for it, and you hope that the reason wasn't a technical one, because that's the one you can control.
And what about repairing repaired? I mean, if it's already been done once, can it be done again?
Yeah, it's a good question. So a revision ACL reconstruction is not uncommon, especially at a referral practice at the university like mine. So it certainly can be done again. I do a fair amount of those. But again, none of these are repairs, so you never can sew the ligament back to itself. That never works. It's like 2 shredded mop ends. You have to reconstruct it with one of these ligaments that you create, a piece of tendon tissue. So if you have one that tears, you can certainly revise it. The drawback is like anything else in life, and that's not just related to ACL surgery. Every time you have a revision surgery, the quality of the outcome goes down a little bit, right? So if you've had your shoulder operated on 10 times, the 11th time is going to do less well than the first time because there's scar tissue, somebody has been there, etc. So it's not that you can't do it and have a great outcome. We certainly do that quite commonly. There's just some other considerations with revision surgery. You have to think about where the tunnels were placed by the previous surgeon, how much those have enlarged, what graft to use now that you've used a graft from the knee already. How big a graft do you need to put in? But it's very common, and I've certainly revised a number of ACLs that still get back to...
So the same tunnels cannot be used again?
Depends on how they were drilled. If they were good tunnels, so in my opinion, I drill good tunnels, so I would reuse my own tunnels. But if they were tunnels that I feel were malpositioned, and that was the reason the ACL failed, then I certainly wouldn't want to reuse those again, because 6 months later it'll fail again. In that case, I often have to graft the tunnels, fill them in with bone, let the bone heal, and then re-drill new tunnels the way I like them. Okay? All right. Thanks very much for coming. Yep.